today's topic is slightly different. We usually discuss here diabetes or cardiology maximum times, but today we will discuss latest advances in general surgery. And when our generations of general surgeons started our career, laparoscopic surgery was not in existence. Then gradually laparoscopic surgery overtook, and nowadays almost all general surgeries can be done laparoscopically, and many surgeries can be done by robotics with the help of robots also. So we have seen many advances in general surgery in last 2 decades. Let us hear from Dr. Vikas Panwar, today's speaker. Dr. Vikas Panwar is a very renowned surgeon. He is Associate Director in the Department of General Surgery and Robotics in Max Hospital, Saket. Dr. Vikas, you can start your talk now. Please, everybody else, please mute your...
Dr. Bhanot, Dr. Poddar, Dr. Bhanot and Dr. S Singh are not on mute. Please request them again to mute.
Yes, Dr. Bhanot and Dr. S Singh, आप लोग mute कर लीजिए. Dr. S Singh.
First and foremost, I thank the Physicians Forum of India for inviting me for this talk. So the topic here, what we are going to discuss is that recent advances in general surgery. So it's a big topic to actually cover up in 1 hour, but we'll try to touch upon the most important things that have happened in the past few sort of years. And most importantly, we are going to focus on things that are practical, that are being done in our unit, that we are doing as a surgeon. So this is not going to be a very theoretical talk where we are going to discuss a lot of theoretical things that can be done, but it will more be practical, so that we all are on the same page after the talk, to understand what has recently happened. So let me screen share.
Dr. HP Singh, mute कर लीजिए.
अभी रास्ते में ऊपर तो जानबूझ के हमने कुछ ट्राई करा है अरे क्या हो गया थोड़ा सा नहीं अरे ये नहीं.
Dr. Khan, please mute yourself. Dr. Khan.
मुझे अच्छा परिवार दो स्टीयरिंग.
Dr. Khan,
Dr. Poddar, can you also allow me to share my slide?
Yes, सर मैंने आपको अलाउ करा हुआ है सर. होस्ट आप कर लीजिए शेयर. डॉक्टर खान,
बाकी जो है ये तो 90% जहाँ स्टडी की है.
Is my screen visible?
No.
Okay, I think it should be available now.
Yes, now it is. Yes, sir. It's not. Yeah.
Okay. So basically, as I started, that we are going to focus on the current management of surgery, recent advances, and our focus is going to be on basically practical things that we are doing nowadays, rather than focusing on theoretical aspects. So we'll try and give you an overview of the advances that have taken place in the last few years. So coming to the first and foremost, as Dr. Poddar said in the introduction, robotic surgery is one of the recent things that have taken place in surgery. We used to be doing open surgeries in the past. Then we moved on to laparoscopic surgeries, endoscopic surgeries, and now we are with robot. So robotic surgery basically is where a console or a computer is aiding a surgeon to do a surgery. So it's a computer controlled by a surgeon's surgery. So it's nothing like, what sci-fi movies, show us a robot completely doing things. So this is not that. The robot is not doing the surgery, but it is being aided by a surgeon, right? So most commonly, what the procedure that we do with robotic surgery at our unit are basically, I'll just go back to the slide. Our rectal surgery, we are focusing a lot on, pelvic surgeries and hiatal surgeries, which are a little difficult with laparoscopy at times. So laparoscopy, more so being sort of chopstick movements, there are two movements that happen away from each other. And robot gives us a much better control in narrow areas. So rectal surgeries are very, very easy and helpful with a robot. Anterior reconstruction. Nowadays, the concept from in ventral hernias has moved away from just doing open surgeries or mesh repairs or what we used to do intraperitoneal laparoscopic mesh repairs to anterior wall reconstruction, where a lot of the techniques have aided mesh placement and repairs in the intramuscular plane. So robotic surgery is very helpful in dissecting and suturing in these areas. It is also aided by a lot of technology. The biggest benefit with robot is we are able to aid a lot of technology like something called as a firefly. This is infrared camera, which with the help of ICG, endocyanine green, helps illuminate the arterial system, the venous system, and also the hepatic system. So biliary system can be very well delineated. So anatomy becomes much more better. We are aided with a better facility what we had with laparoscopic surgery. Mediastinal surgeries, thoracic surgeries with robot becomes very, very nice, and it's aided by a lot of things which I'll just tell you in details. So robot surgery, obviously the idea started initially with trying to do remote surgery. The first concept was are astronauts going to space, and what if they have a medical emergency? How are they going to be managed? So the idea had started from there, where we could possibly do surgery from Earth onto these astronauts if required as an emergency or something in space. So that is where the concept of robotic surgery initially started. Obviously, as I just said, it's a master-slave platform. That means the robot is actually a slave of a surgeon. So whatever the surgeon is doing, it just does the same thing onto the patient through the instruments. One of the first robot that started was an Arthro robot in 1983, followed by Intuitive, which in 1995 came up with the robot. And the first robotic surgery was done in Germany by this Davinci, which is currently one of the best-selling or the most high-tech, used robotic system in our country. Though there are multiple new robotic companies coming up and there's a lot of competition in this area, but Davinci is still one of the standard robotic equipments. So here, as in the picture, you can see there are three components in this robot. First is the patient robotic arm. This is the main robotic arm. 4 arms here which help the surgeon. This is called the vision cart, the second one, which is more like a laparoscopic unit. And the third one is the console that the surgeon sits on. So this is what a Davinci robotic system looks like in a OT. So advantages, obviously it has much more, as you can see here in the picture. The arms are controlled on this by two lever there, which help you do the surgery on the console. You have a binocular 3D vision. This picture here shows you a 3D vision. And this is the camera, which is again a dual camera. So it gives you a 3D with infrared light here, which is one of the state-of-art technologies. So Intuitive has devised an endo-wrist movement with these robotic arms. The tip of the instrument can move in 7 different directions, and all directions can be 90 degrees. So the human wrist, has basically 5 degrees of movements. But this can move much more. It's almost like you can say any movement is possible. Any movement, like a snake movement of the wrist arm, is possible with a robot. Intuitive obviously has a very nice control with your fingers. So it is almost gives you the feeling of doing an open surgery or doing a surgery with your hand, because you are basically using your fingers to the lever on the surgeon console. It has a very nice 3D vision. Magnification is 10 times. Obviously, since the interface has a computer in between, the tremors of a surgeon do not go into the instrument tips. So that filters the tremors if a surgeon has a tremor. And obviously there is something called as motion scaling. That means if you try and move your hand 3 times, you can reduce on the computer to 1. So your 3 times movement can be reduced to 1. There are different parameters where you can reduce your 2 times movement or 4 times. Obviously sitting on a console and doing a surgery generally is said to be less fatigue, but obviously I think longer surgeries you get more fatigued on a console because your head cannot move, your chin is rested on a console, so you cannot move that. Your forehead is always touching the camera area. So it is not easy as said, that the surgeon is comfortably sitting. He is sitting on a console, but it's not comfortably sitting because you have to be totally involved and your movements actually get very restricted other than your wrist movements and hands. The rest of your body is very still. So as I just said, this, the other benefits are endo-wrist movement, thus it makes the surgery very precise. Then the energy source that is available with the robot is state of art. So the normal cauteries that we use, this has one of the best in the world integrated systems of energy sources that helps us in, coagulation. And obviously it has a lot of checks and balances where some errors can be reduced. Infrared camera, 4 arms to the surgeon, all controlled with the surgeon. So these are added benefits. So a surgeon, instead of becoming a 2-arm surgeon, becomes a 4-arm surgeon because the camera is controlled by the surgeon. His right and left hands are controlled by a surgeon, which is in all open surgery, laparoscopic surgeries, as well as the assistant, that is the 4th arm, which is generally held by assistant or is supported by assistant surgeon, is also taken care by the robot and the surgeon himself. So a surgeon here gets to work with 4 hands and all controlled by him. So that gives a lot of benefit in the surgeon knowing what he wants to do, what he wants to move, what he wants to retract and how much. And obviously it's a state-of-art 3D, very nice vision camera. Some of the disadvantages, obviously these are getting, with technology moving forward, these are being ironed out each and every day with every new robot series, like you can imagine with a new phone or with a new car. Every time you buy a new car, you have much more loaded features, and some of the features obviously iron out the problems that you had with the previous one. So Davinci and technology is definitely moving fast and it's moving ahead in a big way. The most common problem that we have in the beginning was we suddenly lacked tactile sensation. So there was no feedback because even in open surgery, you feel everything with your hands. With laparoscopic surgery, you have an indirect feeling because your instruments through the port are touching the organs. So you can feel the softness, the hardness, you can feel the fascia, you can feel something. But with robots, since there is no feedback, suddenly you are attached to a computer and the computer gives the command to the instruments, there is no feedback. So that was a big problem initially, but obviously this is compensated by very good vision and obviously very fine movements. So both of them help you overcome, because this has a 3D vision, which now we have with laparoscopy as well, not that good in quality, but yes, 3D vision is available now without the robot. But initially when we had the 3D binocular visions with robot, that used to give us the best, sort of depth perception, what is behind the area that we are operating on the sides, and that is good enough to overcome the tactile sensation lacking with a robot. But newer robots are getting the feedback. There is something called as a haptic feedback, which is being added to the new robot, and this is a growing technology where the computer tips of the instrument are sensing how much resistance should the surgeon feel. So technology is already working on that. Initially, we had some problem in docking and docking. Obviously, the older versions almost took about half an hour sometimes to dock in. That means to start, to set in the robot, and obviously after the end of the surgery, undocking. But the new system that we have, the XI system, hardly takes less than a minute to dock, and obviously less than a minute to undock as well. Cost is an issue with robot, obviously. Surgery cost becomes higher with robotic surgery. and the basic surgery that we add with gets added, and everything is much more expensive in robot. Like we use the harmonic scalpel, which is a coagulating device. These are a little cheaper with laparoscopy, but the moment they get incorporated or integrated with robot, they become a little expensive. Right now, the technology is expensive. Obviously, with time, technology will obviously become cheaper and cheaper. So the staplers, the hemolog clips, everything that is being used in laparoscopy, when we use that in robot, the cost is much higher. Robot obviously needs a much higher learning curve. It is a totally a different, practice, different skill to, sort of learn. So it needs total dedicated, practice and training into it. And obviously now we have trainings in India. Otherwise we had to earlier go abroad to get the training from US centers. But now thankfully in India we have centers that are giving robotic trainings. The other thing that is a drawback with robot is that the whole team has to be trained. Unlike open surgery where a surgeon knows what he's doing, the rest of the team can sort of follow command. But here, since the surgeon sits on the console and the nurse sits on the patient side, the person who's assisting on the patient side, a surgeon, they all need to be well trained, because the docking, undocking, or the instruments, if they're being removed or added, that has to be done by the scrubbed team on the patient side. Whereas a surgeon is not scrubbed in sterile gown, he can sit on a console without the sterile gown gloves. So that this discrepancy makes your team has to know everything, each step. The nurses and all the staff has to know, rather than in laparoscopy and open surgeries that you can do without much training of the rest of the staff. And obviously, difficulty in conversion initially, there was a lot of difficulty. That means difficulty in conversion means if suddenly there is a problem and the patient is bleeding inside, or there is something has happened in a laparoscopic surgery also, it takes a little while to open up and get in. So is with robot. Here you have to do an added step by undocking as well. So you have to undock the whole, robotic system, then do an open surgery. So that can add a little time. Though we have learned how to, counter if there is a problem, you convert one of the ports to laparoscopy, you hold the bleeder, you remove the dock, you undock the robot, and then you start the surgery. So we are all learning with the problems that we have, and new technology is making robot better and better to, do the surgeries. So this new system that we have at Max is almost now 5 years old. We got it in 2016, and this is one of the latest robotic systems that we have. This is obviously a little superior than the earlier versions of Davinci that we had. So all these integrated things in the the robotic system have helped us a lot. Like the Firefly, I just said, it's an infrared camera. Personalized settings for the surgeon, the moment you punch in your name, so the whole console, height, everything quickly adjusts to the surgeon's preference. Otherwise, in the earlier versions, you had to move every time. And this has a very standardized port practice as well. All ports are 8 mm, so that makes surgery easier, that you can, your camera can move to any arm, your instruments can move to any arm. So interchanging different ports becomes much easier. So that is the advantage of this robot system that we have. So this is a little bit about robot. Obviously with robot you can do all surgeries, as I just said. All surgeries that are laparoscopically possible you can do with robot, but it is slightly better to perform in the pelvis or in the hiatal areas, where reaching these narrow areas can be difficult with laparoscopic surgery. So cholecystectomy, hernias, abdominal wall reconstructions, rectal surgeries like rectopexies or colectomies, liver surgeries. Nowadays, all specialties have become organ specialties. There are liver teams, there are colorectal teams like in the West, and obviously for everybody there is a method to do any surgery, by open, by laparoscopy or robotic. So everybody is using the robot, and obviously the most commonly used department or the specialty is urology, because radical prostatectomy, it is very helpful. So this is one of the areas that I wanted to touch upon in recent advances, robotic surgery. Moving on to the next one, that is recently developed is endoscopic surgeries. So with laparoscopy, initially we did surgeries in the abdomen itself. Then we moved on to open cavities like thorax. So that is a major area, major surgical branch now, video-assisted thoracic surgeries. As well as we have used these instruments into doing surgeries for the thyroid, which and also varicose veins. In our department, we are doing transoral endoscopic thyroid surgery. Obviously, it's a starless surgery. We go through the mouth, and this is how we go in, saving the mental nerve through the lower lip, into the lower lip plane, and then into the neck. From here, the thyroid is removed into the oral cavity, in the mouth. So this is not ideal for very big thyroids or very giant thyroid masses. It is good for thyroid masses about 3 centimeters. If there is a lump in the thyroid about 3 centimeters, you do a hemithyroidectomy, you do a lobectomy. This procedure is very good. But for bigger lumps or bigger masses, thyroid masses, this procedure can be a little difficult because removing the specimen can be difficult. But with benign large thyroids, with the morcellators available, we can do even removal of big thyroid masses through this, but not for malignant lesions. We are so far avoiding malignant lesions doing transoral thyroidectomies. So this is one area which we have moved. Then daycare is the third area that is developing in a big way. So surgeries, even called as fast-track surgeries, or patients, not spending much time in the hospital for routine elective surgeries. So daycare is a major newer development where patient is seen in the OPD, then worked up as a OPD patient, and selected patients can walk in for a daycare surgery. They come in the morning and go back in the same evening after the surgery. So obviously what has made this easy is robotic surgery, laparoscopic surgery, and endoscopic surgery. These modalities have made surgeries much safer and patient returns home much earlier than earlier days. And that makes the patient outcomes much better because these patients who go back early, they are back home early, the recovery is much faster. We see that these patients, we hardly see any patients after our routine surgeries having, atelectasis in lungs, having paralytic ileus, having deep vein thrombosis. So earlier in our training days, a lot of times we used to see patients having deep vein thrombosis, pulmonary embolism, patients in the hospital for 7 days, 10 days. Then they would eventually have a bad pulmonary embolism because of the deep vein thrombosis, and they would succumb to that. So those problems can be reduced by making the patient ambulate early, go back to work early, and minimize their stay in the hospital. So daycare procedure is a major advancement in the recent past, and we have moved a lot of our surgeries possible in daycare where a patient can go back home. So you have to make sure that you use suitable patients for daycare. You cannot have patients who have multiple comorbidities or who will require hospitalization because of their anesthesia-related complications in the hospital. They need to be hospitalized overnight. Daycare is only for patients who do not have major comorbidities or who have manageable comorbidities. It also makes the surgery cost effective. Obviously, patient stays less in the hospital, so the room rent, the unnecessary injectables, antibiotics, which are sometimes not required, they keep going on in the hospital, and that adds to the bill of the patient. That can be reduced as well. And as I just said, early mobilization adds to early recovery. That helps pain management as well. One of the biggest focus that we've had in the recent past is managing patient's pain. Pain is very important for a surgeon to be managed well. Nowadays, we can't have a patient complain of pain after surgery. This is one of the major things that, especially in our unit, we focus on. So we try and do all methods to reduce pain, whether it's during surgery, infiltration of local anesthesia as well with general anesthesia, or keeping the patient on PCA, that is patient controlled analgesia, or oral or IV painkillers, epidurals, whatever required. There are a lot of blocks that are available for abdominal wall. Sometimes we use the tab blocks. So all these are used very, very, very judiciously for all our patients, so that these patients do not suffer post-operative pain. That is one of the most important concerns to a surgeon nowadays, not just doing good surgeries, not just doing state-of-art surgeries, high-tech surgeries, not just reducing complications after surgeries, but also reducing the pain. That is a very, very important and crucial part in management of patients nowadays. So obviously, as I just said, all these surgeries that we do can be done as daycare. Even advanced minimal invasive surgeries can be done under daycare, like bariatric surgery. We are doing sleeve gastrectomies in daycare. Gastric pouches can be done, but we don't do anymore because most of our patients don't want this and are not keen for it. And we ourselves have seen a lot of complication of gastric bands. So gastric band is becoming obsolete. But the other surgeries like sleeve gastrectomy can be easily done as a daycare procedure. So can the upper GI surgeries like fundoplication, Heller surgery. These procedures, the patient can go back the same day. The surgery with laparoscopy, with robotics, has become very, very precise, very controlled. Surgical times have reduced. Patients' hospitalization can easily be reduced and they can go home the same day. So recovery from these kind of surgeries, fundoplication, Heller's, in the olden times, patient used to be in the hospital for a week, used to go home only after their stitch removal and have a lot of complications. All that can now be reduced and patients stay in the hospital can be minimized. So cost-effective, low morbidity, pain, and obviously reducing recurrences in cases of hernias and infections. All this will reduce in daycare. A patient of all kinds of procedures like hernia here, what we're talking about, will make the patient recover much faster, much better. And the procedures also have evolved a lot. Earlier we used to use basically open surgeries for hernia repair, mesh being used for repair. These patients used to have a lot of pain. With the newer methods of doing laparoscopic surgery and going into what we call total extraperitoneal planes or through the abdomen, transabdominal preperitoneal surgery for mesh, for hernia with mesh repair, these have totally changed the way the patient used to be treated earlier. So these surgeries, these newer methods and technology and new ways of doing the surgery removes the patient's anxiety, patient's pain, and recoveries are much faster. So daycare surgeries are preferred for these kind of procedures. So lap obviously is preferred in daycare than open surgery. Most open surgeries is required. We at our unit do a lot of open surgeries, but most are for emergency procedures. We still unfortunately get patients with perforations, obstructions, and these patients are not fit for sometimes general anesthesia, or not fit for a laparoscopic procedure, or sometimes are not suitable for a laparoscopic or robotic procedures, and these patients undergo a open surgery. And open surgeries, obviously day care becomes an out thing. These patients, any patient undergoing an open surgery is not an ideal patient for daycare procedure. But other than that, laparoscopic surgery, very good, outcomes with patient going back the same day. Laparoscopic, as I said, TEP, TAPP, IPOM, fundoplication, all these procedures with reduced pain is one of the most important, crucial, newer recent advances. And obviously you need a team to do all this. You have to have a good anesthetist, you have to have a nursing team, dietitian, physiotherapist, and even a very good home care department. Because if a patient goes home and they need help, the integrated team contacts the patient the same evening. If there is a need of a nurse to visit or a doctor to visit at home, that can be arranged. Though we seldom ever require a doctor to go home and see a patient after surgery, but a nurse sometimes may be required to go home if a patient has some difficulty in passing urine, requires catheterization, or some kind of fever that requires an injectable, paracetamol to be given to the patient. So for these things, a nurse can go home, and a good home care team backing up is required. Here you can see here, this is a patient operated for a hernia, laparoscopic repair, and this is a patient just 2 hours after surgery. He's totally awake, he's totally ready to go home, he's got a catheter, as you can see here in the picture, that we sent the patient on the catheter, especially this patient who had a prostate, mild prostate and was on anti-prostate medication. So we keep the patient on a police catheter and the nurse goes in the morning and removes the catheter.
So you can phone call.
Single port surgery, this is obviously a scarless surgery. We have moved on from laparoscopy where we used multiple ports to single port surgery. The robotic surgery, robot is going to, the Davinci is soon going to have a single port device which is available in the US but not in India so far. Sooner we are going to have that, and that is going to be a big game changer in management of all abdominal or laparoscopic or endoscopic surgery patients, where a patient will not even have a scar, will have a surgery done through a single port. And these single ports obviously made through the umbilicus makes it scarless because there are no more cuts elsewhere. Obviously nodes was, that is natural orifice techniques were being done a lot. We did that about 8-10 years back, but then advantages were not so high. The instruments were not geared up to manage the narrow area that we had to go through in these patients. So single port now are getting relaunched and devised in such a way that all those problems that we had in the past can be ironed out. So another area that we want to focus here, or I would want to mention here, is fistula treatment with video assisted or minimal invasive fistula treatment, as we call it. MAFT also, minimal video assisted, MAFT, WAFT, all these are names to endoscopic treatment of fistula. So obviously a fistula tract is visualized, the internal opening is examined, and through the external opening we put in an endoscope, small endoscope and very fine endoscope, and through that the internal tract is completely burnt. And nowadays laser is making a good comeback. So laser assists burning the tract from inside. We close the internal opening, or we do a lift procedure, as we call it, intersphincteric ligation of the fistula tract, and that helps a lot in these patients of fistula who used to undergo a surgery with very big incisions, with very big wounds requiring dressings and treatment for months, and the wound would take long time to heal, and then still have a recurrence after such a major time spent by the patient and undergoing so much of pain, agony, and still finally having a recurrence of a fistula. So these minimal invasive procedures have made life very easy for our patients. They start walking the same day. They have hardly any dressing to be done. A small hole which needs to be just, small dressing can be done on it. So that makes the recovery a lot better. This has been a major game changer in the fistula treatment, as well as in pilonidal sinuses, where the same technique can be applied for a pilonidal sinus, which was again majorly done by open surgeries with major wounds requiring months and months of dressings for the wound to heal. This is the fourth topic that I wanted to cover gently, or just give you an overview: anterior wall reconstruction. So major changes here in anterior wall reconstruction now, as I just said. So we do a surgery in the intermuscular planes, that is the external, internal, oblique, and transverse abdominis. So there are anterior approaches, there are posterior approaches, there is something called as a TAR, that is transverse abdominis release, E-tip procedures. So a lot of procedures, a gamut of procedures here. Almost more than a dozen procedures are currently available, different techniques available to do anterior wall reconstruction with endoscopic techniques, other than the old-fashioned open techniques or intraperitoneal only mesh repairs. Generally, we focus these anterior wall reconstruction surgeries for large hernias, 6 centimeters or more, and a lot of options here to manage these hernias. Bariatric surgery, this is of the 6 topics that I wanted to cover. This is the 5th topic. So this is a major, change in the recent past. Earlier, we had to, tell our patients that bariatric surgery will help reduce weight. Then in the next 10 years, we have realized that not just it is helping in reducing weight of these patients who are morbidly obese, but also reducing their comorbidities. So a lot of their comorbidities like diabetes, blood pressure, all these are getting well, treated with bariatric surgery. So this is a major change in the recent years. And obviously, there are two kinds of procedures that we do: restrictive procedures or malabsorptive procedures, or a combination. So there are a lot of procedures available now. This is also changing in a big way. So sleeve gastrectomy, as most of you must be well aware of, this is one of the commonest procedures that we are doing world over nowadays. Almost 2/3, or maybe some countries are doing more than that. This has become one procedure that is considered to be most easy to perform, most easy to learn, most easy for the patient, minimal side effects, and by minimum change in GI system. There is no change in anatomy or too much change in physiology. So it's one of the closest to natural procedures. We just remove a sleeve of the stomach, and that causes reduction in eating and a lot of hormonal changes that aid the patient reduce weight. So this is one of the best procedures to be performed, though there are a little new known complications like reflux can get higher with these patients. Obviously, malnutrition like anemia because of lack of intrinsic factor. All these things can be a little higher. Roux-en-Y gastric bypass, this is currently the second most common, but used to be one of the well-known procedures in the past. This was the first procedure that actually became successful. So we create a gastric pouch that reduces the stomach size, and then we make a long limb that causes malabsorption. Obviously, there are a lot of advantages and disadvantages. Losing good weight is one of the best, and not having reflux diseases is a very good advantage. But nutritional deficiencies definitely are higher in Roux-en-Y gastric bypass compared to sleeve gastrectomy. So a lot of other procedures also like band, pancreatic ductal bypass, OAGB available. So what I wanted to focus here on bariatric surgery now we are focusing a lot on the nutritional imbalances after bariatric surgery. So most of our bariatric patients with whatever procedure we do have a lot of nutritional deficiencies, and in spite of trying to correct that with medications, it is still refractory, or it is not easy to treat. So like we see almost about half our patients having anemia after bariatric procedures because of iron, folic acid, and vitamin B12 deficiency. A lot of these patients have osteoporosis because of vitamin D deficiencies, calcium absorption is reduced, and minor micronutrients like thiamine, vitamin A, zinc, all these have been seen to be very significant in our patients post-op recovery. They reduce their weight, so they look better. They have their comorbidities treated. They are much happier. But then in the long term, they have nutritional deficiencies which become very refractory for treatment. So we have been focusing on this, and as I just said, this is the normal absorption. So intrinsic factor from the stomach, most of the absorptions in the proximal jejunum and duodenum, and obviously vitamin B12 in the terminal area. All these get somehow changed in all the procedures that we do. Whether we do a sleeve where the intrinsic factor is a problem, or we do gastric bypass where all these areas is bypassed and very little is left here for vitamin B12 absorption. But since intrinsic factor was not there for the food to combine in the stomach, even the absorption of vitamin B12 is very minimal. So that is a problem with most of our patients. Reflux disease, as I just mentioned, it's a problem with sleeve gastrectomy. With bypass, it's not, and this can be relieved with doing a bypass procedure. I'll focus on a procedure that will help reduce, correct, or address all these issues, that is nutrition, reflux disease, and the third problem that we have with our patients is pregnancy. Patients who are in their reproductive age group undergo a bariatric surgery. They have problems in conceiving because nutritional deficiencies, especially in the first 1 year, are very difficult to handle. So we advise most of our patients not to undergo or try to avoid pregnancy for at least 1 year. So the other problem with nutrition is obviously childhood. So childhood obesity and adolescent obesity, here these patients, if they undergo a procedure that is currently available, they will have a long-term nutritional deficiency. And these nutritional deficiencies in children or adolescents is again very difficult to manage in the long term. So for this, we have devised a procedure called as a physiological gastric surgery, which is again a very novel procedure that our unit is doing. And this procedure basically makes a micro pouch where the patient eats less, gives them an elementary long limb, which causes malabsorption, so they lose weight by these two, and then the food comes back into the stomach and goes through the normal process. So they get back their intrinsic factor, all the calcium, vitamin, absorption, and B12 in the terminal ileum. So this procedure has addressed nutritional deficiencies and which will help our young patients doing bariatric surgery, women wanting to conceive, and even correcting the reflux disease. So this is one procedure which helps take care of all the problems that are currently associated with current available bariatric procedures. So obviously the advantages, weight loss is there, comorbidities resolution is there, post-op anemia resolutions are there, osteoporosis, GRD resolution, pregnancy can take place earlier, safer in even adolescent, and weight regain will be much lower in these patients. So last a little bit, I think we are already we are almost 50 minutes into our talk. We'll just give you a brief talk on the laser as well. So laser is because of new branding by a lot of these TV ads, as you see Hrithik Roshan, branding laser for piles, and so this has been rebranded and revisited again. So laser was obviously used earlier in the late 90s, then again in the late 2010s we used to use laser for hemorrhoid surgeries, but it did not show very good results in long term. But again, there are not much of evidence so far. There are not much of randomized trial from authentic sources to say laser is a preferred treatment for hemorrhoid surgery. Only for hemorrhoid I'm talking right now. But yeah, there are a lot of centers which are promoting it, which are saying that this is a good method. We do laser in our center as well for selected patients, and we do it for generally grade 2 or grade 3 hemorrhoids. For grade 3 or 4 hemorrhoids, stapler surgery is still the best. And the advantage of a laser surgery is that the patient goes back the same day as a daycare procedure, and it is obviously painless compared to stapler hemorrhoidectomy. The pain is more or less the same, recovery is more or less the same. Long-term results we have to see. So far it looks good, but in the long term, like maybe 5 years, 10 years, we'll have to wait and see how the results are compared to our well-known stapler hemorrhoidectomies. But definitely I prefer a laser treatment for fistulas, as I said, and pilonidal sinuses, because these are still, we don't have any other good method to treat them. We do a video assisted and a combined laser treatment, and the combined results are way better, much better, and the patients are much lesser with wound care post-operative. So these are the basic 6 topics that I wanted to cover, so that you can get a brief overview of the recent advances that have taken place in research. Thank you so much, Dr. Poddar.
Thank you, Dr. Vikas. I think almost everything you have covered in last 1 hour. So now I think before I ask all the delegates to ask the questions, few lines I will comment. Robotic surgery, as he has said, It's very good for surgery for rectum or prostate or any other deep spaces like hiatus hernia also. It's very good. And robotic surgery, of course, it negates your effects of tremors. Yes, surgeon's tremors are not having any effect, and they can do almost 360-degree movement. You see, your wrist moves only for 90 degrees, but with robot you can do almost 360-degree movement. But I think it has no advantage in simple laparoscopic surgery like laparoscopic cholecystectomy. It will unnecessarily cost will increase by almost 80,000 to 1 lakh, depending on the centers. So in simple lap chole, I think there is no role. But in, of course, rectum surgery, CA prostate, hiatus hernia, or even at bariatric surgery nowadays, there are robotics being used and with good advantage. Regarding single port lap surgery, I am not sure whether it is better because I have discussed with many laparoscopic surgeons and many have then stopped now doing this single port lap surgery. Maybe some new instrument will come, then we can see how good it is. And regarding pilonidal sinus surgery, you said open surgery requires months to heal, which is not true. Nowadays, we can do excision of pilonidal sinus and closure of the wound by rotation flap, which gives only patient has to come for 2 dressing, one for drain removal and next for stitch removal after 10 days. But anyway, the major advantage in many surgery, like he said, mainly in fistula and sometimes pilonidal sinus, but most of the time, lasers are more for advertisement. It has no real advantage. Because the layman, anything which is not done open, they think it is done by laser, whether it is laparoscopic or anything robotic. So laser in real sense has advantage in very few surgeries. I think Dr. Vikas, like he said, in some fistula surgery, VAP or some pilonidal surgery, some hemorrhoid selected cases. Thank you, Dr. Vikas. Now the floor is open for the delegates to ask the questions. Anybody can unmute and ask the question.
I'm Dr. Prashar Rao,
Yes.
Yeah.
I'm an ENT specialist. So we are using some other nice interventions like assisted coagulation therapy. We are using basically plasma as a cutting edge tool. Any idea of any use in the abdominal surgeries for coagulation?
No, we haven't used that, and nobody has used that. There is not much of data on that to be used in abdomen. But yeah, I know ENT is using that, and it's very good for ENT patients, but not here in abdominal surgery as of now. We haven't used it, and there isn't much data on that.
Actually, in general surgery or laparoscopic or robotic, harmonic is very good. But
So we have much more better devices like harmonic, Vigasure. So these devices are already taking good care. So we don't probably need anything of that sort as of now.
The other advancements are something like instead of this sutures we have or the staplers we have, now we can have even zippers for closure of the wound. So any use of those. Similarly, glues are coming up in a very big way. You can seal the wound with the glue. So are you using glues on a regular basis on the cut edges of the stomach when you do sleeve gastrectomy or something?
So definitely glue has a good role, and zippers were very fancy about almost 2 decades now. So during our post-graduation days in the 1997, we used to use zippers for laparoscopy wounds. Patients were they had an ischemic gut, we had done a resection, you are not sure whether the edges are going to be fine, so you had to do a relook, or for certain cases where there was a lot of infection, you had to go back and wash it again. So we used to do a lot of these laparoscopy procedures where the abdomen was left open, but you had to go back in, and that is when the zipper procedure came in, and we did use that in our patients. frankly, it was a very cumbersome thing, didn't give any advantage, and unfortunately, most of these laparostomy requiring, zip requiring patients were so sick that they would eventually, succumb to their primary problem. As for the use of glue, we use glue in most of our patients, especially glues for the, skin. Our patients, are laparoscopic, very small cuts. These patients, once they have glue, the biggest advantage is it seals the whole wound. So they can have a bath for the same day. They can, sit in a pool after 6 hours of surgery once the glue has totally dried off. So that helps them go back to their normal activity, bathing, and doing their normal activity helps them a lot. So glue is very advantageous for the skin. Internally, using glue has not shown much, good benefit. We have used glue for, trying to fix the mesh, trying to use it at the edges of the sutures, but there the results are not so good. With glue inside the abdomen in a wet area, so far the available glues have not been very useful. So,
with MST, is the declared date of fistula is lesser?
So that, when we did just the video-assisted fistula treatment, the recurrence rate was almost 40%. When we did the laser treatment with the fistula treatment, with a video-assisted for fistula treatment, then the recurrence rate have come down to 15%. With the best possible procedure that is open that we do, the recurrence rates are somewhere between 5 to almost 40% depending on the type of fistula that we have. And as far as the pilonidal surgery is concerned, again we did a lot of these flaps where the biggest advantage, as Dr. Poddar said, was a big advantage in the wound care, but the recurrence rates increased a lot. So open surgery, pilonidal sinus had a recurrence rate of about 5 to 10%. But the graft or the mobilized flaps, there the recurrence rate became higher, almost going to 50-60%. So a video-assisted fistula treatment or a laser treatment combined has reduced that a lot. So this is becoming a very good modality for fistula as well as for pilonidal sinus.
Dr. Poddar?
Yes.
Dr. Poddar,
Yes, sir.
Yeah. Can I ask one question, sir?
Yes.
Yeah, Dr. Vikas, a lovely talk and to impressed us by the latest advances in surgical procedure. I have a small question. I basically practice thyroid disorder as a physician. We normally recommend two group of patients. One is the cancer thyroid, that is follicular, papillary, or anaplastic. And in case there is a multinodular goiter which is large, what other indication you are doing a thyroidectomy or semi-thyroidectomy surgical procedure? We don't find many indications for surgical intervention in thyroid disorder. Can you guide us to what other indication you've been doing surgical procedure in thyroid?
So as you just rightly mentioned, so cancer is one of the commonest and the most increasing, thyroid disease that is requiring surgery. So obviously most of them are papillary carcinomas and the lesser ones are follicular carcinomas where a total thyroidectomy helps. Then obviously, as you said, the nodules, toxic nodule requires surgery if it is a single nodule. Multinodular goiter requires a subtotal thyroidectomy. Other than that, a lot of these indications that we had earlier, like, doing a surgery for a thyroid cyst, is becoming less and less and is becoming obsolete because the patient is very happy getting ultrasound guided aspiration, getting a cytology done. If it is negative, they are happy to watch it. Though 15% of these cystic, 5 to 15% of these cystic lesions can also be malignant. Though, in spite of that, these patients are generally happier with 1 or 2 aspirations, and that takes care of the problem that we had. And the generalized thyromegaly or, mild thyromegaly where we did it for cosmetic reason, again, that is becoming obsolete now. Most patients do not require and are not indicated for even doing a total thyroidectomy for just thyromegaly with no lesion inside. So a lot of indications for thyroid surgeries have changed, you are right, and the surgical indications have reduced now. So for cancer and for toxic nodules, These are the only ideal sort of indications. Other than that, a lot of them have a gray zone, and a lot of them depends on patient choice, surgeon choice, depends on the patient's general condition. So all those things will take into consideration for the other indications.
Thank you, Dr. Vikas. We hardly recommend any patient now for thyroid surgery except the cancer surgery. We like to give the
Dr. Panwar sir, can I ask you a question?
Thank you.
Very true, very true.
Yes, continue. Dr. Panwar sir, I have a question, sir. Yes. Sir, Dr. Vikas mentioned about laser being used in when you use lasers, do you still require staples for the surgery, or there is no need for staples? You only require lasers.
I lost your voice, so I'm not sure. I think you are referring to laser in pile surgery, is it?
In surgery. In surgery for hemorrhoids, when you use.
So not for pile. Pile, you either use a laser or you use a stapler. So we generally use a laser treatment for grade 2 or 3 disease, and we use a stapler surgery for a grade 3 or 4 hemorrhoid.
Dr. Chauhan, with stapler we don't use laser, but one minute, Dr. Chauhan. With laser, we are sometimes using Doppler guided hemorrhoidal artery ligation. That we can use in third degree piles. Doppler guided hemorrhoidal artery ligation plus laser can be used, but not with stapler hemorrhoidectomy.
Yes.
Absolutely. Doctor, in the bariatric surgery, the switch operation is more physiological. Is it getting more and more popular now?
We are the first. Yes, absolutely. We are the first center to have started this, and we have just published it in a few journals and presented in international forums. So this is just the beginning of it. It will take a little while to become popular and well known, and we'll have to also wait for long-term results to see anything else that needs to be addressed in the long term. So far in the early Sorry?
Have you found any disadvantage of this procedure?
No, not at all. So far, the only thing is that this requires more anastomosis. So generally, the sleeve gastrectomy is a long staple line, whereas the gastric bypass has 2 basic anastomosis. Here we require 3 anastomosis. So 1 anastomosis is added, so this requires a little more skill and technical expertise. So it is not like the sleeve gastrectomy, very simple to perform by any surgeon. It needs training and experience in doing this procedure.
Thank you, sir. Thank you.
Right.
Yeah. Dr. Chauhan, you were asking some questions. Yes. Sir, I think my voice is breaking in between. Sorry for the poor network, sir. Sir, I want to ask Dr. Vikas touched upon some of the surgeries, and I was interested in knowing what is the role of lasers in the vascular surgery today, especially the varicose
veins. Yes, absolutely. So that is one area I did not touch.
Although not in max, the vascular surgeon would be doing.
Yeah, so we are doing varicose veins at our unit as well. And I did mention in a small slide, we do both procedures, something called as a SEPS, that is subfacial endoscopic ligation. That is one surgery that we do, and the other is laser surgery. So ablation of the varicose veins by laser. So both procedures are being done, and even open method like we used to do in the earlier days, that is ligation of these veins. So these procedures are being done in our unit, and it shows very good results. So varicose vein laser has a good role, as you mentioned. It has definitely got a role.
Sir, can I ask a question, Dr. Jacob?
What is the cost of this laser surgery for varicose veins in your setup, in both the lower limbs?
So we are the added cost. So far, we have not added any other cost other than the laser. So rest of the things stay the same. So laser for us is being, is adding about 35 to 40,000 to the surgery. So basic surgery used to be about 70,000. So this adds about 35,000 to the surgery.
So it's about a lakh for both the lower legs?
Yes. Laser surgery is about a lakh for one leg. Both legs would make it about 1.5.
Is it covered under CGHS in your setup?
Yes, it's covered. Absolutely.
Both for CGHS as well as for CGHS?
No, at Max Saket, where I am practicing, we have CGHS, not ECHS. ECHS is in the other block called Max Smart. But we don't have ECHS, we have CGHS.
Are they doing laser ablation in Max Smart?
Max Smart, no, not in Max Smart.
Okay, so it's being done in your setup?
Yeah, it's being done in our unit, our block.
Yeah, over to you, Dr. Poddar, sir.
Yes, Dr. Vikas, on one point I don't agree. You said when we use excision and flap closure for pilonidal sinus, the recurrence rate is 50%. This is, I think we have done around 30 cases. Of course, I take help of plastic surgeon initially in Apollo Hospital with Dr. Pankaj Mehta, and I have not seen even a single case recurrence in 30 cases. This was in last 3-4 years. And the only thing is you have to excite wide excision. You have to give wide excision. When we do with flap closure, I even do wider excision than open surgery. That when we used to leave it open, and then we do flap closure, and after the wound is healed, we advise patients for laser treatment for hair removal. If you do in that area laser treatment for hair removal, in many series I have seen hardly recurrence of 1%.
We have, unfortunately, we've tried all of that, but we saw very high, recurrences in our practice. So
it cannot be more than open, because we are doing excision. We are as wide as in open surgery. So there is no chance for recurrence more than open surgery.
So our patients probably, because of contamination, stool is close by or whatever reasons, we saw in our own series, the recurrence rate was 38%. And we have not done a flap surgery in the last 3 years now because of that.
One doctor came from Patna last month. We did in Apollo, and he was very happy. He went home after 10 days and with no wound. And we have advised him to go for laser permanent treatment for hair removal by laser.
Absolutely correct. That flap surgery is a well recognized treatment option for pilonidal sinus, and you have to excise the tract nicely, and you have to do a wide excision.
Wide excision.
And you have to go deep till the sacral fascia. So all those precautions have to be taken nicely.
Excision is same as in open surgery.
Yes, absolutely.
We sometimes go wider. Thank you, Mr. Vikas, for a very nice, informative lecture. Thank you.
Thanks so much.
And any other comment, or over to Dr. Chauhan for closing remarks.
All right, Dr. Poddar sir, for wonderfully moderating this session, and Dr. Vikas Panwar for a wonderful insight into the latest and recent advances in general surgery.